Welcome to the Attention Deficit Disorder Expert Podcast Series by Attitude Magazine.
Hey everyone, it's Susan Kaufman. I'm here today for Attitude Magazine's ADHD Experts audio series. Welcome and thank you all for joining us. As many of you know quite well, ADHD is very often accompanied by one or more additional disorders. In fact, in the last few months, we have welcomed speakers on a number of conditions that are frequently diagnosed alongside ADHD. We've had speakers on depression, on anxiety disorders, on bipolar disorders, and today we are very pleased to welcome Dr. Roberto Olivardia, who will talk about OCD, or obsessive-compulsive disorder. And he will address such questions as, what is OCD? How is it different from ADHD? Why do doctors often miss OCD in people with ADHD or vice versa? And why is having both ADHD and OCD different from just having one or the other? And what does it mean for treatment? Dr. Olivardia is a clinical psychologist and clinical instructor of psychology at Harvard Medical School. He specializes in the treatment of ADHD, of body dysmorphic disorders, and obsessive-compulsive disorders. He wrote a book on various manifestations of body image problems in men and maintains a private psychotherapy practice in Massachusetts. Dr. Olivardia is on our Attitude Scientific Advisory Board, and we are very grateful to him for all of his contributions. Thank you so much, Dr. Olivardia, for coming today, and welcome.
Thank you very much for having me. And this is a topic that I feel very passionately about, as I treat a number of people with both ADHD as well as OCD and people who have both. With obsessive-compulsive disorder, there are a lot of different misinterpretations of what we actually refer to. So we have two categories. We have the obsessions and the compulsions. So by obsessions, we're referring to recurrent, persistent thoughts, impulse, or images that are seen as intrusive by individuals and cause a tremendous amount of anxiety. So these aren't just kind of the worry thoughts that some people might have about, whether their kid is going to do well in school that day or whether an upcoming exam. I mean, these are just thoughts that are really intrusive, that even at times that people don't engage in wanting to think about them, they really hit them and they cause a lot of distress. And people with OCD will attempt to ignore these thoughts, try to suppress them, or often neutralize them. And what I mean by neutralize is sometimes they'll develop certain compulsions of trying to undo the thought. So let's say if someone were to have an obsession that their mother is going to get breast cancer. And again, this would occur in the absence of anything that's reality-based. So this could be an individual who has no family history of breast cancer, whose mother is completely healthy, but suddenly has this very intrusive thought that their mother is going to have breast cancer. And the thought is so large and very impactful that they then try to think about something else to try to undo the thought. A compulsion is a repetitive behavior or some kind of mental act that somebody will feel compelled to do in order to neutralize an obsessive thought or undo it or try to reduce the obsession. So we often think of compulsive behaviors when it comes to OCD with things like washing hands. So if someone who has contamination concerns, they touch a phone or a doorknob and they start to have an obsessive thought of, oh my gosh, I have lots of germs on my hands. These germs can cause a deadly disease, which then I'll die an early death, and then I could potentially contaminate other people. So that anxiety becomes so high that they're compelled to perform a compulsion. In the case of contamination, it will often include washing hands or sanitizing. But there are many, many different forms of OCD. That's just one of them. Other forms could include mental rituals, such as what we call scrupulosity thoughts, people who have an obsession that they just offended somebody or did something that really wronged somebody, and as a result fear that they're going to go to hell or fear that God is going to punish them. And so they might have to do certain compulsions like praying a certain number of times, or the compulsion sometimes doesn't even have to be connected to the obsession. It could be counting something in sevens. It's just something, whatever the mind is telling them that they have to do. And these are not things that they want to do. They hate doing the compulsions, but the anxiety is so high with these obsessive thoughts that they feel compelled to. So when we think about OCD, we often don't think about ADD in the mix, but actually studies will show that 30% of people with obsessive-compulsive disorder also have ADHD. We are not clear as to the percentage of people with ADHD that also have OCD. We know that 30% of people with ADHD have an anxiety disorder, and OCD is one of many different anxiety disorders. Other anxiety disorders are things like panic disorder, phobias, generalized anxiety disorder. So we don't have clear studies looking at specifically of the percentage of people with ADD that have OCD. But we do know, and certainly what I see in my practice, are individuals who have both OCD and ADHD. I find that the types of OCD that I see very prevalent in ADHD populations typically are grouped in these four categories, although again it could be any form of OCD, but I often treat people who have what's called the pure O OCD, which is more the pure obsessional types. So you can still get a diagnosis for OCD even if you don't have any physical compulsions. The compulsion could be mental, a mental compulsion. So even if somebody is just obsessive, they still qualify for the diagnosis of OCD. So individuals who have just very, very obsessive thinking, obsessive thoughts. It could be perfectionism. It could be obsessive thoughts that they have wronged somebody. They could have obsessive thoughts of feeling like that they've done something immoral. They can have obsessive thoughts about whether they contaminated something, and perhaps it won't result in a compulsion to wash their hands, but they'll just be left with this thought, this tormenting thought that they're contaminated. Hoarding, which we often think of as a form of OCD, and it is for a lot of people who are hoarders, but I see a lot of individuals with ADHD who also are hoarders, and it's a little bit different in the sense that a lot of ADHD individuals might end up compulsively shopping and buying things, and then either not returning them, not placing them where they need to be, and then before you know it, their places become complete messes and very disorganized. But when people have both, I often see that high comorbidity of people who have both the OCD and the ADHD when it comes to hoarding. Tourette's disorder, which is conceptualized as within the obsessive-compulsive spectrum of disorders, is I see a lot of people with ADD with the kind of profile of ADD, OCD, and Tourette's, or having various tics, whether they're vocal tics or behavioral tics. And then the last category is a category that very little is known about, but I actually wrote an article for this that should be coming out soon about body-focused repetitive behaviors, which by that we're talking about trichotillomania, which is compulsive hair pulling, dermatillomania, compulsive skin picking, compulsive nail biting, cheek biting, any of these sort of behaviors that feel very compulsive. Now, these are been typically grouped under the rubric of obsessive compulsive disorders, but I see many people with ADHD who engage in these behaviors, and some of it is to relieve anxiety, which is what you would typically see in OCD individuals, but also a lot of ADD individuals are drawn to the sensory or stimulating aspects of these behaviors, which sort of satisfy the ADD. When we think of OCD, though, OCD in and of itself is an attention disorder. It's an anxiety disorder, but it's a disorder where attention really is the core issue. The difference is that unlike ADHD, where people, let's say, might be inattentive or might be distracted, people with ADD are drawn towards that which is stimulating to them, that of which is not boring, which is pleasurable. People with OCD have a hard time focusing and concentrating because they have selective attention to threat-related stimuli. So unfortunately, they are not distracted by pleasant thoughts. They're constantly distracted by thoughts that present as threatening to them. So if they're in class, for example, this might be the student that might look like they have ADD because they're not really paying attention to the teacher, but it's not because they're being distracted by something pleasurable. It's that they might be thinking, if I don't get every word of what the teacher is saying, I'm going to fail the course. And if I fail the course, I'm not going to get into a good school, and then I'm going to be a failure at life and be homeless. And that sort of type of thinking makes them want to get every single word of what the teacher's saying. And of course, that thought and is in and of itself being the very obstacle that's enabling them to get any of the words that the teacher's saying. So it becomes this real bad vicious cycle. People with OCD also have a large difficulty in filtering out irrelevant data. So even neuropsychological tests have found that people with OCD have a hard time prioritizing information and saying, okay, this is the most important thing, this is the second most important thing, this part isn't very important. It's almost as if the brain captures all of that information as important. And we see that even in behavioral things like hoarding, for example. People who are very classic obsessive-compulsive hoarders are individuals who can't throw out anything, partly because they can't distinguish what is something I really need versus what is something that really should be trash. It all feels the same to them. And of course, having obsessive thoughts in and of itself is going to be distracting from whatever it is that you're doing, which then gets in the way of a person with OCD being able to focus and concentrate succinctly on what they're doing. So when we understand that, it does seem, at least at first glance, that ADHD and OCD are two just complete opposite ends of the spectrum. We think of ADD individuals as being very spontaneous versus people with OCD as being excessively planful. People with ADD are more impulsive. They're acting before they think. People with OCD are quite compulsive. They're thinking too much before they make an action. People with ADHD are pleasure seekers. They're oriented to their environment by that of which gives them pleasure. People with OCD are oriented to their environment by how they can avoid anxiety. However, we still see these comorbidity rates, and actually one of the reasons that we'll often see this high comorbidity is because of what's called non-random mating, and that many people with ADHD tend to marry people who are on the obsessive-compulsive spectrum and vice versa. And so as a result, those genetics get mixed in a pool and they have children, and some of those children will have ADD and some will have OCD and some will have a combination of both and some will have neither. But with this high comorbidity, it's striking how often either of these disorders can be missed when in the assessment or treatment of the other disorder. ADHD, I've often seen it more where the ADHD is missed or underemphasized in my OCD patients. I see many patients with OCD whose ADHD has not been diagnosed until my work with them. Part of it is that ADHD is rarely assessed, particularly in adult clinical samples, that it's still seen as an academic issue solely. It's still seen as simply an issue with focus and attention as opposed to the executive functioning deficits that come along with ADD and all of the different life domains that we see that ADHD can impact. So people have very wrong perceptions of what ADHD is. I had a child that I was treating recently with OCD, and it was clear to me that the child also had ADHD, and I presented it to the parents, and the first thing that the parents said was, oh, I don't think he can have ADHD. He can focus for 10 hours straight playing video games. And I understand why the parents would think this, because in our culture we think of ADD individuals as not having any attention span. And when I said to them, well, actually, that's not what ADD is. So people with ADD can focus for long periods of time if they are provided with a certain level of stimulation. And in fact, many of my ADHD patients are playing video games for many, many hours straight. We often will see the ADHD and OCD symptoms intertwine. And what I mean by that is, for example, I had a patient years ago who was diagnosed with OCD, and she would describe all of her various rituals, and one of them was meticulously cleaning her room. Now, when I asked her a little bit more about what that meant, she said that in order for her to focus on writing her paper, she had to first rule out any distractions in the environment, and so she would start cleaning her room because any amount of mess or disorganization would just derail her from the level of focus that she needed to write her paper. Now, any other day of the week that she's not writing a paper, her room was a mess, and she was completely fine with that. But on days that she had to write a paper, she looked, quote-unquote, very OCD, but it wasn't OCD. What she was doing was actually a behavior that was managing her ADHD. Someone with pure OCD would be bothered by, with that kind of OCD, would be bothered by a mess and disorganization any day of the week. Likewise, you can see it on the other end where I worked with someone who had what looked like attention deficit disorder solely, and they did have the ADD component, but when I queried them more on this was someone who was a student who had a very hard time in class and focusing and getting the assignments down, and as a result of not writing the assignments correctly would forget their homework, and it would create, and it presented in the ways that many of those of you who are hearing this might think of classic ADHD. And he did have ADHD, except when I inquired further into that, it turns out that he was writing down the assignments, but he was writing down every single word. So if a teacher said, okay, make sure that today you read chapter 2 in the green textbook and read pages 43 through 46, what any one of us should be writing is chapter 2, green book, page 43, 46. He was writing, please make sure you read chapter 2 in the green book and make sure you read pages 43 through 46. And as a result, wasn't able to get all of the information. He had a very high obsessive degree of perfectionism that not only came out in those academic ways, but in leaving the house, he had to be very symmetrical with the way his hair was. He had to make sure that when he shaved, it was very symmetrical. He had a lot of perfectionism issues that were very classic OCD issues. The other thing is the confusion between hyperfocus and overfocus. And what I mean by that is people with ADHD can be quite hyperfocused, where they're engaged in a task that they find very stimulating, or there's a degree of urgency attached to it, and they move fluidly through that task, but to the exclusion of anything else that's going on around them. Versus someone with OCD, they can get overfocused, which means that they're not moving fluidly through the task. They're actually quite stuck in the task. So they're feeling quite anxious, and it's almost like they're not able to take in what's going on around them, but they're also not moving fluidly. And of course, many times the inattention that we see in ADHD is often seen as secondary to the OCD. Now, as a result, we also see that OCD can be missed in ADHD patients because of all the misconceptions about OCD. Not everybody with OCD has contamination fears. Some people with OCD, many people with OCD, are messy. These are all the assumptions that we have about that all people with OCD are clean freaks or things like that. That's not the case. That stuckness that I was mentioning before that people with OCD could find themselves in is sometimes misinterpreted as the lack of following through on something, which many people with ADHD have issue with. And shame is a very, very big component. Many people actually with both of these issues of OCD and ADHD are marked with a tremendous amount of shame. Now, with that comorbidity, it's very important that people understand that there are certain consequences that come with that. Now, there are a collection of studies, I wouldn't say a large body of literature, but the collection of studies that look at individuals who have both OCD and ADHD and comparing them to people who simply have OCD or just have ADHD. And it turns out that having both, not surprisingly, is associated with more social problems, more academic problems, and more attentional issues. And with the treatment of OCD, that we would look at OCD first. There's a psychopharmacological approach, so that would be with medication, and the treatment of choice psychopharmacologically are the SSRIs, the selective serotonin reuptake inhibitors. So that includes Zoloft and Luvox and Celexa and Prozac. Now those medications don't really do anything for the ADHD. I mean, they might help the ADHD only as so far as that they help the OCD. So they don't really hurt or harm the ADHD symptoms. Now, psychopharmacologically, for ADHD, we often have the class of stimulant medications, and the thing that we see, or I've seen with my patients, is that the stimulants can sometimes help the OCD if the OCD is highly related to the ADD, but in a number of cases, unfortunately, the stimulant medication can make the OCD worse, because what it's doing is enabling somebody to focus better on the very obsessive thought that they're trying to not have. So it's kind of a tough thing, and individuals who engage in body-focused repetitive behaviors sometimes find that those get exacerbated with stimulant medication. So in those cases, oftentimes the person will take the SSRI for the OCD and treat the ADHD component more behaviorally. Cognitive therapy, which is looking at reducing the negative thinking and inaccurate thoughts, trying to challenge that, find evidence against the obsessive thoughts. But the hallmark treatment for OCD is exposure and response prevention therapy, or ERP. And what that basically is confronting the thoughts, images, objects, and situations that make a person with OCD anxious. And the response prevention would be making a choice not to do the compulsive behavior after coming into contact with the things that make that person anxious. So to give you an example, and this looks like a treatment that looks sadistic, it looks like counterintuitive, but it is the gold standard of treatment of what helps with OCD and has been found to be just as effective, if not more effective, than medication. So if somebody has contamination fears, because people with OCD work so hard at avoidance, that's going to make their life more and more isolated and small, you might have that person touch the bottom of a shoe. You might eventually work towards a hierarchy of having them touch a dirty toilet and putting their hands on a dirty toilet seat or in a toilet bowl, and then not washing their hands for an hour or two afterwards. And what happens in ERP therapy, or exposure and response prevention therapy, is you want the person's anxiety to rise, only so that they can eventually habituate or tolerate that level of anxiety. Now, you can't have something that's at a level 10 where they're going to have a panic attack. It has to be something that's at like a level 7 or 8. You would work with your therapist to develop that hierarchy. But what goes up must come down. If somebody is connected to their anxiety and not working at suppressing it, the body will not maintain a high level of anxiety towards that object for a sustained period of time. Now, it can, if what you're doing is trying to push it away, it's going to come back to you. You're going to push it away, it could come back to you. That can happen 24/7. But if you're actually sitting with the anxiety, it will reduce. I promise you, it will reduce. It may take time, but it will do. This is essential. So anyone out there who's getting treatment for OCD, if your therapist does not do this kind of therapy, it's not going to be as effective. I mean, the cognitive therapy alone could help for mild OCD, but for any moderate to severe, you have to have that behavioral component. And last but not least, before I go into questions, is really the importance of acceptance, that first and foremost, before any treatment for ADHD and or OCD, is having somebody really be on board with understanding that there's no shame in having either or both of these disorders, that there are many accomplished individuals who have both ADHD and OCD, that this is not an issue of willpower. If I just try harder, I'll be able to focus more. If I try harder, I'll be able to not have this obsessive thought. OCD in particular is a tormenting disorder. It's associated with the high rate of depression, of suicide, of substance abuse. It's a very, very difficult disorder to treat. And OCD and ADD actually fall under these sort of cultural rubrics where people are like, oh, I'm so OCD, or oh, I'm ADD, and not really appreciating or understanding the gravity of what that really means to live with both ADHD and OCD, and particularly the two combined. So when somebody can get to a place of understanding that this isn't their fault, that they don't have to have shame around it, then they open themselves up to really delving into the treatment, which is hard. It won't be easy, but at the same time, recovery is absolutely possible. I'm affiliated with McLean Hospital, which is a psychiatric hospital in the Boston area that has a residential program called the OCD Institute that treats people who are diagnosed with treatment-resistant OCD from all over the country. They come to this program, and it's very exposure response prevention based, and after a couple of months, they leave that program with a whole new lease on life, feeling very liberated, not cured, but liberated from the real weight of their OCD. So I'll open up for questions and answers.
Thank you so much. That was a great overview. Can you just talk for a minute about OCD in terms of the genesis of it? I mean, I think we sort of have the idea that ADHD is neurotransmitter related. Do we have any sense of the origins of OCD?
Yes, OCD also has a genetic component. So if you have OCD, there is a high likelihood that you'll have a child either with OCD or one of what we call the OCD spectrum disorders. So that can include any of those body-focused repetitive behaviors, anorexia nervosa, generalized anxiety disorder, and you'll often see OCD run in families. So there's a high genetic component, and then there are studies that are looking at brain imaging studies that are looking at particular aspects of the brain. And one in particular is called the caudate nucleus, which has been implicated in OCD in the basal ganglia. And we're not sure exactly what it is about these brain parts, but we know that there's something about those brain parts that are quite active in individuals with OCD.
Interesting. So yeah, someone has asked, is it the is the amygdala, but it sounds like, and where is it located in the brain? So I guess that's still in this being worked out. Is that right?
Yeah, the amygdala is sort of our emotional center of our brain, and the amygdala definitely gets activated, overactivated for people with OCD when they're confronted with a threat-related stimuli or what they think is threat-related. But we don't think that the origin is in the amygdala, that another part of the brain is communicating to the amygdala and saying, oh my gosh, this is a life-threatening situation, and the amygdala is just doing what it should be doing under a life-threatening situation, which is to try to have that person fight or flee. Unfortunately, the amygdala is getting the wrong message from those parts of the brain that these are not, in fact, sort of life-threatening situations, but it feels that way to the person with OCD. And I'm not even talking about behavioral situations. It could be a thought. You know, if you have a thought that you're going to get cancer unless you pray 50 times, and your brain says, yes, you need to pray 50 times, otherwise you will get cancer, the person will say, well, if what I have to do to reduce my anxiety is to pray 50 times, I'll just do it. The problem is that obsessions and compulsions tend to get worse over time if the person doesn't treat them.
So that's actually one of the questions that people have asked. When do OCD symptoms manifest themselves? How are they diagnosed, and does it indeed get worse over time?
Typically with OCD, we'll often see the age of onset. Parents will say that they've seen traits in their children at very, very young ages. Kids who were a little bit on the cleaner side, who might have had tantrums if things weren't symmetrical in their room, like little kind of red flags, but nothing that would have been diagnosable as there are some kids that might have those same issues that never have OCD. But where we really see the age of onset will typically be in adolescence, where you'll start to see the symptoms really flare up. Now, for people who have both OCD and ADHD, you tend to see the symptoms flare up earlier. So I see kids as young as 8 who have full-blown diagnostic OCD, and a lot of them also tend to have ADHD. The symptoms do get worse over time, so it's imperative that you get treatment as quickly as possible, because it's not impossible. I mean, I've treated individuals who have had OCD for 40 years and can do very, very well with treatment. It's just harder. The longer you have it, the harder it just becomes, because your life sort of starts to accommodate it in so many ways. And many people with OCD don't realize all the things that they might be avoiding or accommodating, or the ways that family members, unfortunately, and I don't blame them for this, might be accommodating the OCD.
Interesting. So treatment's really imperative. Can you talk a bit about diagnosing ADHD? I'm sorry, OCD. What's the process, and who should people look for a diagnosis?
Absolutely. I think that it's very important, just like I always tell people who are looking for ADHD assessment and diagnosis and treatment, that it's important to see somebody who really is a specialist in ADHD, because there are lots of therapists who say they know a lot about ADHD, but they really don't, honestly. With OCD, I would say the same thing. There's an organization called the International OCD Foundation, which is the umbrella organization for OCD and OCD-related disorders. They have a great website. They actually have an annual conference that will be in Boston this year. And on their website, they have a treatment provider listing where you write the city that you live in or your zip code, and it'll tell you people who are members of the International OCD Foundation. And these are individuals who are trained, who have expertise in OCD. And they'll ask you basically a lot of questions. There are certain rating scales that they might use, such as something called the Y-box, the Yale-Brown obsessive-compulsive scale, but take a very comprehensive, detailed history. And most importantly, teasing out, is it OCD? Is it anxiety? Because even though OCD is an anxiety disorder, there are lots of other anxiety disorders that are not OCD. And particularly if you have ADHD, teasing out what could be the OCD versus the ADHD. So it would be a very thorough clinical interview with someone who really has a full understanding of what OCD is.
Okay, that's super helpful. Can you repeat the name of the organization? That sounds like an important
Absolutely.
piece of information.
It's called the International OCD, or International Obsessive-Compulsive Foundation, the IOCDF. And they're a great organization based in Boston, but they have listings of treatment providers all around the country, actually I believe all around the world, who specialize in OCD.
So iocdf.org, possibly. Right.
I believe that's the website, yeah.
Yep, okay. So talking about treatment, you outlined does the treatment vary by the type of OCD? OCD sounds like a complicated disorder with many different subtypes. Which are the treatments that work best, for example, for anorexia or for trichotillomania? Two topics that listeners have brought up.
So in general, with OCD, although the manifestations of OCD might be very different, the treatment approach would be similar in terms of exposure response prevention therapy, in a lot of cases medication, and the cognitive therapy. It just might look a little bit different. So for someone with contamination fears, their ERP, or exposure and response prevention, might be to put their hands on a dirty toilet, whereas if somebody who has obsessive thoughts about a loved one getting breast cancer, and those obsessive thoughts result in them avoiding anything that has the word cancer in it, or if they hear the word cancer, they'll have to pray a certain number of times. Their ERP would be having them read a Wikipedia page, let's say, on breast cancer, or actually writing a script. And I know this sounds really hard, but writing a script that says, my mother is diagnosed with breast cancer, my mother was and almost write it as if it's happening, so that you're really not avoiding the thought, and in fact, you're sort of you're engaging with it, you're immersing yourself in the thought. Now, with things like related disorders like anorexia nervosa, which is an eating disorder, but it's not unusual to see many boys or girls with anorexia who also have OCD. And we know that even if they don't have full-blown OCD, that it is sort of within that family of disorders. Very important that you see someone, obviously, who has knowledge of eating disorders. With anorexia, you have to have a multidisciplinary team of a physician, a nutritionist, a psychologist who with expertise in eating disorders, and often OCD as well. And it would be first and foremost nutritional rehabilitation to get a person to a sort of more stable weight, because when somebody is in a starved state, even people who don't have OCD, our brains actually reduce to a very primitive obsessive-compulsive state. So the more underweight somebody is, the more obsessive-compulsive they're going to be about things. So it's so important to first just work on the nutritional components and the fear that they might have of food. With trichotillomania and those kind of behaviors, that would be a little bit different in that there are these behavioral techniques called stimulus control and habit reversal. So that would involve, for example, trying to engage in the parts of your body that you would normally use for that habit, but either blocking it or engaging in something else. So, for example, for trichotillomania, somebody notices that when they're sitting and watching TV, that they might start touching their hair, and then before you know it, they find the right hair and they pull it, and then it starts 2 hours of pulling. You might have that individual, if they understand that watching TV is a trigger situation for them, you might have them wear gloves while they're watching television. They might put lotion on their fingers so it's harder to get that grip of the hair. They might wear a hat while they're watching television. They might have a squeeze ball in each hand. So all of these things are ways of trying to basically break that kind of automaticity, the automatic nature of those kind of behaviors.
Okay. So, and questions still about treatment. Is it generally covered by insurance? It sounds like cognitive behavior therapy is probably not done by a psychiatrist. Is that right? It's probably done by a therapist, a specialized therapist.
Correct, yeah. With cognitive behavioral therapy, or CBT, I mean, some psychiatrists are trained in therapy, but most of them are not. So it would be done by a psychologist or a therapist that specializes in CBT. And in fact, it is often more covered by insurance because CBT there's a lot of empirical data that show for some individuals pretty dramatic results. Unfortunately, standard sort of psychotherapy or talk therapy, which I think has certain value, absolutely, often is under more scrutiny by insurance companies because it's not measurable. Whereas in sort of strict CBT kind of modalities, you can say, okay, these are the 5 symptoms that we're targeting. This is the treatment plan, and we can actually measure if you're obsessing 10 times a day or 1 time a day, if you're washing your hands this many times a day. So insurance actually will favor a cognitive behavioral model over a more what we call psychodynamic model.
Interesting. Yeah, makes sense. Is OCD always associated with anxiety? There are a couple of people on the webinar who, one person says, I've evaluated a 10-year-old boy. His behavior or checklist doesn't suggest anxiety, but he has both OCD and a tic disorder. So do you see OCD without any sort of obvious anxiety component? Can you see that?
Typically, we wouldn't see straightforward OCD without anxiety. So OCD is inherently an anxiety disorder. However, that individual, that boy, might have either be on the autistic spectrum, so we see a lot of individuals with Asperger's, for example, who present in very obsessive-compulsive, very ritualistic, stereotyped ways, but without any anxiety. Or there's another diagnosis called obsessive-compulsive personality disorder, or OCPD, which is slightly different than OCD, in that people with OCPD are very perfectionistic, very ritualistic, have very precise ways in which they do things, but it's not ego dystonic, which means that it doesn't cause them distress. It will cause people around them more distress.
Oh, wow.
They tend to be individuals who are highly moralistic and have a very hard time with people not doing things their way. So you'll often see sort of narcissistic traits. So these are individuals who, let's say, might, if guests come in their home, might not want anybody sitting on their couch. And, but then it's not even so much that they're anxious. They just feel that that's sort of just what it should be, and have a very hard time sometimes understanding that other people would react to it that way. So by OCD, we would see anxiety, but with OCPD, we often don't see anxiety. We see an individual who really is wedded to these behaviors, and it's often problematic interpersonally in their relationships.
Okay, that's really interesting. Are there any general books that you would recommend to someone on the popular side of, in the same way that we, think of Ned Hallowell's Driven to Distraction as a great introduction to ADHD? Is there something similar for OCD?
There are a lot of great books. I mean, one that comes to mind, one of my favorite, is by an OCD expert in Pennsylvania. Her name is Edna Foa. That's F as in Frank, O-A. Edna Foa, and she has a great book called Stop Obsessing, and it's very user-friendly to read. It's very practical, great exercises. It tends to focus specifically on the more sort of purely obsessional aspects, although it could also include sort of more compulsive aspects. There's another book called OCD in Children and Adolescents, and the name of the person escapes me, but I know that's the title of the book, OCD in Children and Adolescents. Another good book called Brain Lock. Another one that specifically focuses on what we call bad thoughts OCD, which is a type of OCD where people have intrusive violent or sexual thoughts. And this is particularly distressing and one of those things that, unless you're an expert in OCD, can often misdiagnose. So these are individuals that, let's say, might have a thought, like I have a patient now I'm working with who he has these intrusive thoughts that he's a pedophile. And so when he looks at a child, He thinks, am I looking at this child because I'm sexually aroused by them? Do I want to have sex with them? Oh my gosh, I'm such a bad person. And meanwhile, he doesn't masturbate to the idea of children. He doesn't have any of these thoughts. And that's the irony of it, is that individuals who suffer from this form of OCD are the least likely to engage in these kind of behaviors. But because he's thinking of it and it makes him anxious, he assumes that the anxiety is basically a confirmation that in fact he must be a pedophile. And so a great book for that is a book called Getting Control, and it's written by a colleague of mine at Mass General Hospital named Lee Baer, B-A-E-R. And it talks about those kind of thoughts. And again, the treatment would be sort of exposure-based. So when I have a patient now who has intrusive, violent thoughts that he's going to stab his mother, and he's never been, this is again very different than homicidal thoughts where someone has a desire and an engagement. They have arousal when they have these thoughts. The person with OCD has no desire. They're broken up by it. They're devastated by having these thoughts. But this is someone who can't use a steak knife in the presence of his mother because he has this intrusive thought that he's going to stab her. So the ERP that we did, believe it or not, she came into the session with him where we had to have a whole session where he held a knife to her throat.
Ooh,
and
wow.
This sounds like, crazy, but it totally helps because, of course, his mother knew he wasn't going. I mean, this is one of the most sensitive, caring, compassionate individuals, which is why this thought was so terrible for him. And when he was able to get through a session, granted he was, completely anxious, and realized, wow, like here I have a knife to my mother's throat and I didn't stab her. Maybe I don't really want to stab her. And of course the OCD at the first thought says, well, maybe it's because, Dr. O is in the room and that's why I didn't stab her. So he had to continue doing these at home with her. And then, fortunately, over time, the thoughts just starts to dissipate because the power of an OCD thought comes in the intrusion of that thought and it comes in the avoidance. So the more one avoids and the more intrusive and the more one pushes that thought away, it's actually giving the very power to the thought.
Interesting. So, wow. Yeah, so I can just see how with the wrong therapist, the diagnosis might be seriously mistaken.
Yes.
Wow. Yeah, very sad. There are a couple of parents who are saying that their children have certain OCD symptoms, but they've been told that until it's very disruptive, they shouldn't worry about it. It sounds like your response to that is treatment is important, or even early on.
Certainly. I would say that it's definitely important to just fully assess and make sure that, again, this is an individual who has OCD experience, because it is true that it's common for children to have OCD-like behaviors who never develop OCD. Because children also, it's developmentally appropriate for children to sometimes get very literal, very rule-bound by things as a way of them learning rules in the ways that we all do. And so if you're, told to write your name on the line, children who are trying to be good students who don't have OCD are very astute to that. And then, as we mature, we realize, okay, there's flexibility here. Like, it doesn't have to be that. And also, a lot of kids can sort of grow out of it. So keep your eye on it. Now, if you have a family history of OCD, I would definitely look at that in a very different way, because when you have a family history of OCD or an OCD-related disorder, I would err on the side of seeing a therapist, and you're not going to induce the OCD. If the person really doesn't have OCD, you're not going to cause it by bringing them to a therapist. So at the very least, you see an OCD therapist, they work with your child a couple times, and they say, you know what, this is actually pretty under control. I wouldn't worry about anything. Then you're good. But sometimes, again, because we see this sort of behavior, similar with ADD, I mean, we'll see, lots of kids. Teachers might say, well, lots of kids have a hard time with organization and so forth. That's true. However, if you know it to be sort of in this excessive way, and if you have a family history of ADHD, you don't want to dismiss it, as quickly, because it really can be something that could be sort of intervened with and nipped in the bud. And I've seen kids as young as 6 who have OCD.
Wow. Okay. Here's an interesting question. Is OCD a legal disability? there's any protection against job discrimination for it? That may not be your bailiwick, Dr. Olivardia, but I'm guessing you probably know.
It definitely falls under, it is a mental health diagnosis and a mental illness. It absolutely. So I have patients who have OCD who are protected in the sense that they cannot be discriminated against for the purposes of having that diagnosis. So
Okay.
it falls under the Disabilities Act.
Okay. Can we talk a little bit about the shame component of this? One of the reasons I bring it up is because Julie has asked a question about talking to her son about this disorder. He's been diagnosed with both ADHD and OCD. And the psychologist that she works with has discouraged them from using the term with him, saying that he might feel labeled. They feel that it possibly be better to have a recognition of the disorder and recommend it, but they're wondering if age 8 is perhaps too young. How do you talk about these things, and how does shame play into that labeling issue?
Definitely. I am a huge proponent of naming it for what it is and defining it for the child. And this is true when it comes to ADHD. This is true for dyslexia. This is true for OCD. Yes, I mean, the risk of being labeled is how the child is then going to understand and define that. But as their parent, you could say, okay, there's this thing, called OCD, and this is what it does. And there are a lot of people that have it, and you might even want to find some famous people that your child might relate to, whether if your child is a sports fan, an athlete that might have it, if they're a movie fan, an actor that might have it. So having some face that goes along with it so they don't think of themselves as being alien or the only ones that have it. And saying the good news about a name is that we know when there's a name for something, it means that people have studied it and people can know how to treat it. And so that's the good thing. And then I would also validate that if it's you or your spouse or someone else in the family that has either OCD or some aspect of it, that it helps for that child to know that even within their family, they're not alone. Now, maybe they might have it to the degree that they have it or the extent that they have it, but I know that, for example, having ADHD myself, that I have a son with ADHD and dyslexia, that it was very important when he was diagnosed at 6. I told him the terms and I said, this is, Daddy has ADHD and these are the other members of the family with ADHD and reading issues and all of that. All of this is within the family. Like, we all can relate to it. Now, I might not be able to relate, or I'm not saying that I know exactly what that person is going through, but it's important for them to know that they're not alien even within their family. And
Right.
The reason I'm a proponent of that is because as they get older, granted this child is young, but as they get older, you want to firmly define it for them, because what happens, and I've seen this a lot, is that, and I get it, I mean, parents, obviously, we always want to do the best to sort of protect our children and make them feel empowered, is as they get older, when they start hearing about something like OCD from other sources and other ways, and they think, and they relate to it, and they know inherently that they're different in some level, then they're going to start getting shame about it. Whereas you can, particularly when they're young, you have more sort of pull in trying to diffuse the shame, and that's going to be
Right.
the most important piece of it. This is nothing to be ashamed of. It's just, and trying to use kind of examples for them that happened to you, because as a child, they look up to you as a parent, and it's very important for them to see that even if you're not the one with OCD, or if you don't have OCD, to say, sometimes I have thoughts that just, I can't get them out of my mind, and it's so frustrating, and it's important to share that with the child so that they see it as something that mom and dad can relate to in some ways, even if they don't have the diagnosis.
Okay, that makes sense. And you just have that little window when they're young to really establish that this is okay before the world around them may start to make them feel shamed.
Definitely. And you can refer to it as the monster, or, I have my child patients, and even I have adult patients that refer to their OCD by certain names, and that's fine, as long as they understand that this is this thing called OCD, and we could call it something else, but they have still this firm understanding that, and I think if they're in treatment, that when they're seeing a therapist that says, yes, I have specialty in this very thing that you're struggling with, this very thing. So because a lot of children get very hesitant or could be very fearful of therapy because they're like, how is this person supposed to get into my brain? Like how, I mean, not just children, adults too. Like how is this person really supposed to understand this? But if you tell them, actually, I am not an expert on you as a person. That's where our relationship is going to come into play, and you have to tell me about who you are. But I can tell you that I have a good understanding of what OCD is and how to work with it.
Okay, interesting. Interesting question from Anna. We know that ADHD is associated with social immaturity and children being, I think Dr. Barkley says 3 to 5 years behind in sort of development. Is that also the case with OCD?
Not necessarily. In fact, what's interesting is that with OCD, it's associated with a high sort of complexity of sort of thought, in that many people with OCD have been tested as being average to above average in intelligence. So it's almost like, sometimes I'm in wonder of the complexity of how people with OCD can even hold on to all of these obsessional thoughts and compulsions and rituals. We'll often see sometimes people with OCD or kids in particular might have this almost like this dichotomy of where they carry the weight of the world on their shoulders. They're almost like old souls in a way. They have this kind of almost like this sense that they're thinking in ways that you just don't want them to. You want them to be thinking carefree and immature. Like a lot of the parents of kids that I work with, they wish their OCD kids were sort of very immature in the kind of that they were involved in kind of immature things. It's almost like they're thinking too much like an adult. However, socially, because they're individuals who are almost thinking too much in that way of an adult, that they do have a hard time sometimes relating to peers who don't think in those terms. Many of their peers are not, I'm working with a boy right now who, for his friends, they play touch football. They get in the dirt, they get all mud. That's sort of like a sign of boyhood, for a lot of these boys. And here's my patient who has very intense contamination fears as well as OCD thoughts around ruining the earth. And so he feels that if he's digging up dirt, he has these obsessive thoughts that he's being a bad environmentalist. And so he has these thoughts of not wanting to harm the earth in the slightest way. And so how does he do this? So as a result, he started to avoid these activities. And as a result of that, you're not going to grow socially in that way. So yes, we do see the social immaturity, but for different ways and by different mechanisms than we do with the ADHD.
Interesting. Okay. There's something called PANDAS, which I guess can be related to OCD. A number of participants have asked you to distinguish between PANDAS-related OCD and, I guess, pure OCD. Could you comment on that?
Absolutely. So with children, there have been in these situations where children who seemingly don't have any sort of obsessive-compulsive traits and then really almost overnight after developing sort of these certain strep infections, and I don't want to alarm people that it's like strep throat. It's a very, very specific streptococcal bacterium that basically almost can develop OCD symptoms overnight. So PANDA stands for Pediatric Autoimmune Neuropsychiatric Disorders Associated with Streptococcal Infections. And these are a very specific group of symptoms where individuals basically develop these symptoms overnight. So the treatment would actually be similar. The causality to it is still a bit mysterious. So we know that though the presentation can be very similar. So it's important to certainly get it assessed and make sure that there's an understanding of whether this is PANDAS, but the treatment would be fairly similar if the person is engaging in obsessive thoughts or behavioral rituals and such like that.
Okay, that's interesting. The teacher who says, I have a jaw cracker. Any suggestions to help him stop ADHD and OCD present in her student?
Yeah, so typically with that kind of behavior, you want someone, it's almost as if the ADHD is saying, okay, particularly if they're sitting in class, that their body is almost like releasing energy because they have to sit still. And so we often think of like fidgeting as a way that people can release that energy. But now people also have the sort of OCD component of these body-focused repetitive behaviors. It could be the jaw cracking, the knuckle biting, the cheek biting. All of those things become a mechanism of which somebody could be either grounding themselves or soothing themselves. I might recommend that person, let's say, chew gum, which might, if they're allowed to chew gum, because that would sort of give their mouth kind of that stimulation. It's very, very difficult. Unlike with OCD, these body-focused repetitive behaviors, I mean, I can't even emphasize enough how difficult and impairing trichotillomania, skin picking, all of these behaviors are. The person feels completely compelled to do it. And so it's important that it's not just an issue of, oh, well, just stop doing it. They really need something else to sort of substitute it or work with it. So having gum in their mouth might be a good way, or something to sort of chew on. It's very, very unrealistic to assume that that person can just not do it anymore.
Right. It's a really tough one. Let's see. Oh, here's something that's interesting. It's a reference to something that you mentioned. This person is a psychologist who treats adults with ADHD and notices a huge overlap between hoarding behaviors and ADHD. She is wondering whether there's more to it than just difficulties categorizing things. Could you comment on that, and any treatment strategies you would recommend for patients who present with both hoarding and ADHD?
Definitely. So we see with ADHD hoarding, it's a combination of these sort of executive functioning deficits. So first is the acquisition of items. So sometimes with hoarding, the problem is in the acquisition of the items. The person might be an impulse spender or a compulsive shopper, for example, and they're buying things and then either not putting them in its sort of appropriate place, or thinking, oh, I should return this, and then it just doesn't end up, getting done. In addition, is that because people with ADHD have a very hard time motivating themselves to do something until it's drastic or urgent, with something like the organization of your home, a lot of times people with ADHD will wait until their house is in complete disarray or disorganization. But the problem is that they might have the desire to clean it then, but they don't even know where to begin to sort of do it. It's just too overwhelming for them. And so as a result, these things sort of pile up. In addition, many people with ADHD will, again, not always have distress around the hoarding, because they'll say, well, I know where all my piles are. I know where everything is. Maybe this is uncomfortable for you to walk into this, what you call disorganized, but it's actually quite organized. For me, many people with ADHD need things very visually accessible to them. So putting something in a drawer or in a file is very tough. They need everything out. But the problem is when you have a lot of stuff and everything's out and you have particularly a small space, it's going to be a really big problem. Now, with the OCD component is also then how do you get rid of things, how to begin doing that. Now, someone with OCD, a classic OCD individual, is very dead set against anything being thrown out. And if you've ever seen the show Hoarders, can get quite belligerent and quite hostile at people who are suggesting that they need to throw out stuff. They feel very wedded to the idea that they need that thing, or the possibility that they might need that thing, and if they don't have it when they need it, they're going to get very anxious. So again, the anxiety is a major component. With someone with sort of classic classic ADD, these are individuals who would welcome sometimes a professional organizer or someone to come in and help them clean up, sometimes to the point where they'll be happy to leave the house and come back to a totally organized house. However, the combination is that if they're the ADD person who, let's say, has their piles out in a certain way, then they're going to be quite anxious because they're going to come maybe to a clean house, but they don't know where now anything is. Their organization system has sort of blown up. So now they need a new way of sort of organizing. So you'll see the anxiety in that component. The OCD hoarder might acquire things sort of more over time, or they might have sort of other mental health diagnoses like bipolar disorder, where they might go out and buy 20 pairs of boots, let's say, of the same pair of boots and not return them. So there is a lot of definitely that overlap. So it's working with the executive functioning deficits, but the more sort of pushback that you see, the more you're seeing kind of more that obsessive-compulsive style, which
Interesting.
The studies show a very, very poor prognosis actually with very severe hoarding and OCD. Yes. It's one of the most difficult forms of OCD.
Wow. That's, yeah. Oh gosh, we're running out of time. A couple of great questions here. There's a teacher who asks if you can suggest accommodations for students with OCD in the school setting.
Absolutely. I mean, it depends on the form of OCD that they have. But if, let's say, you have a student that has perfectionism issues, and this is someone who becomes so paralyzed that they can't write notes because they're trying to get every word, having, a note taker, for example, in class that relieves them of that. And it doesn't mean that this is something that they're not going to work on. I mean, they would work on it in their therapy of how to work through this, but I have students, for example, who reread things, which again can look like ADD if they read a page of text and have no comprehension for it. You want to specifically ask, did you actually read it? And if you ask them questions, a lot of my OCD patients will tell you exactly what was in that page of text, but they feel compelled to reread it because they're afraid they might miss something important. So as a result, they might read something 5-10 times. The ADD individual will not have comprehension because they were distracted the whole time and really did not read the text. So you can have audiobooks that are accessible to people with ADD and dyslexia that could also be useful for people with OCD. So depending on the form of OCD, absolutely, you can write in accommodations into their IEP.
Okay, great. We're out of time. I just want to end with a wonderful story that was posted by Deborah, whose son, who's now 25, was diagnosed with OCD at age 8 and followed by ADHD soon thereafter. She says that he struggled with medications for years and ultimately found a therapist at McLean, the hospital that you're associated with, Dr. Olivardia, who did both CBT and ERP, and he's actually in great shape. He got a medical waiver to join Naval ROTC, is now an officer on a submarine with no apparent signs of either problem.
Awesome.
And so, so that's a great story. Thank you, Deborah, for posting that. Thank you so much, Dr. Olivardia. This is extremely helpful. A great, clear overview, as always, from you. We appreciate your time so much. And thank you, everyone, for listening in. We appreciate your time. Bye.
Thank you.
For more Attitude podcasts and information on living well with attention deficit, visit attitudemag.com. That's ADDITUDEMAG.com.